Welcome to our October 25th Downtown Rotary Club of Sioux Falls meeting. I'd ask that you stand for the Pledge of Allegiance. Please remain standing for our invocation. Almighty God, who sent your Son, who went about doing good and healing all manner of illness and disease, continue, we implore you, your gracious work throughout South Dakota and this region. Specifically today, we ask for your healing in our rural and underserved areas. Grant physicians, nurses, and all healthcare professionals wisdom and skill, sympathy and patience. Keep them safe and preserve them from all contagion. Cheer, heal, and sanctify the sick, and send down your blessing on all who care for them. In your name we pray. Amen. You may be seated. We have a full slate today, and excited on a number of different levels. We're going to go ahead. I know we have a number of guests here. While we aren't going to call you out specifically, we do want you to know that you are very welcome, and we're glad that you are with us today. We have 3 junior Rotarians with us this month, 2 of which we're going to hear from today. We heard from Isaiah Mulder, Sioux Falls Christian, last week. Isaiah is here. Welcome. And very shortly, we're going to hear from Morgan Whiting and Charlie Mickelson. So welcome, you two. As you came in for the second week in a row, you received a sticker with regard to polio. And while he's not able to be here today, the mayor of Sioux Falls has, on behalf of all 4 Rotary clubs here in Sioux Falls, declared today as World Polio Day. And I'm going to read that proclamation right now because I believe there's some important information regarding Rotary's role over the last 3 to 4 decades in our work to eradicate the polio condition. Whereas Rotary is a global network of neighbors, friends, leaders, and problem solvers who unite and take action to create lasting change in communities across the globe. Whereas the Rotary motto, service above self, inspires members to provide humanitarian service, follow high ethical standards, and promote goodwill and peace in the world. Whereas Rotary in 1985 launched Polio Plus, and in 1988 helped establish the Global Polio Eradication Initiative, which today includes the World Health Organization, U.S. Centers for Disease Control and Prevention, UNICEF, the Bill and Melinda Gates Foundation, and Gavi, the Vaccine Alliance, to immunize children of the world against polio. Whereas polio cases have dropped by 99.9% since 1988, and the world stands on the threshold of eradicating the disease. I mentioned last week, so far this year, 2 known cases, one in Afghanistan, one in Pakistan. Whereas to date, Rotary has contributed more than $2.2 billion in countless volunteer hours to protecting near 3 billion children in 122 countries. Whereas Rotary is working to raise $50 million a year, which would be leveraged for maximum impact by an additional $100 million annually from the Bill and Melinda Gates Foundation. Whereas these efforts are providing much needed operational support, medical staff, laboratory equipment, and education materials for health care workers and parents. Whereas in addition, Rotary has played a major role in decisions by donor governments to contribute more than $10 billion to the effort. Whereas there are over 1.2 Rotary members in 36,000 clubs throughout the world that sponsor service projects to address such critical issues as poverty, disease, hunger, illiteracy, and the environment in their local communities and abroad. Whereas the Sioux Falls Rotary Clubs, including downtown Sioux Falls North, Sioux Falls South, and Sioux Falls West, have participated in Rotary's polio eradication efforts. Now, I therefore, Mayor Paul Tenhaken, Mayor of the City of Sioux Falls, do hereby proclaim October 25th, 2021 as World Polio Day in Sioux Falls. And my understanding is, while I've been working on polio the last 3 to 4 decades, we're now using a lot of the lessons learned and the infrastructure built to help vaccinate the world for our current pandemic. Next, I'm excited to bring to the stage Kayla Etram, and Kayla is going to introduce our junior Rotarians today. With that, Kayla.
Good afternoon, everyone. I always say I have the most fun volunteer job in Rotary, to get to spend some time with our high school students and work with them to have them speak with you. Like Tony said, we do have 2 students speaking with us today. First, I'm going to introduce Morgan Whiting from Jefferson High School. She is involved in basketball, student council, link crew, best buddies, student ambassadors, tutoring, National Honor Society, and is involved as a religious kindergarten education teacher and was recently named to the Mayor's Youth Council. Her mom is here, Jen Whiting. Welcome. Thank you for joining us. And she plans to focus on political science and would like to be an attorney in the future. So please help me welcome Morgan Whiting.
Hi, I would just like to start by saying thank you for giving me the opportunity to share a little bit about myself with you all. And what I'm going to tell you about is, I'm going to tell you a story about an obstacle I've had to overcome in my life in my high school career. All right, so it was October 8th, 2017, and this was the day I became a state champion as an 8th grader. And this was the proudest I'd been of myself in what felt like to be a long time. Doubt continuously clouded my thoughts when people told me I was a talented softball player, but then I stepped into the pitcher's circle that night and struck the first batter out. As the late night continued, we got closer to the trophy, and all my team could feel was excitement. The adrenaline was pumping, for me at least, and it worked in my favor because I got the rally going in the last inning with a base hit. Then I ended up on second due to my teammate grounding out. Next thing I know, the best hitter on the team is up, and all of a sudden, I'm ignoring my coach telling me to tag up, and I'm rounding third base, galloping stupidly across home plate. Then I saw my teammate round third towards me, and then just like that, it was over. We won. The excitement I felt was indescribable, but little did I know, a year in the future, I wouldn't be playing in the state championship. I would be watching it from the bench, accompanied by some crutches and my stitches. Honestly, I was doing great that year up until May. In May, I began to feel this clicking sensation in my hip when I moved in any way, shape, or form. At first, my athletic trainer said, "Oh, you just pulled your hip flexor. No big deal, keep playing." So I played for 2 more weeks. Went to basketball open gyms, played some softball tournaments. But as the clicking sensation lingered, my mom began to worry a little bit more. So the next thing I know, I can barely walk after pitching 5 games in a row for my travel team in our tournament here in Sioux Falls, and my mom is setting an appointment for the doctor's office. After the x-rays, I was put on crutches for 2 weeks because the doctors couldn't tell if I had a stress fracture or tore my labrum. Both of these would have been caused due to the overuse of pitching. After 2 weeks, the MRI results came back, and I learned that I tore a part of my body that I didn't even know existed up until now. My labrum. So the doctors gave me 3 options: participate in physical therapy, get a cortisone shot, or get surgery. I opted for physical therapy because that meant that I could keep playing sports. And I participated in therapy religiously for the rest of the summer, doing whatever I could to feel healthy again. But it just wasn't enough. I had surgery in September and thus began the longest 6 months of my life. Recovery killed me mentally because I felt helpless. Sports had been my life for so long, and I couldn't even run at this point. I felt like a part of me was missing. Nevertheless, I pushed through and came out the other side. By the end of March, I was completely cleared and ready to play, but pain in my hip continued. But I told no one because I was supposed to be healed because I had the surgery. I played 2 full seasons of softball with an aching hip before realizing the pain just wasn't worth it anymore. After many talks with my parents and some difficult conversations with coaches, I stepped away from the sport I loved, the sport I had played for 13 years. The decision I made this past winter was the hardest decision I have made in my life thus far, and it left me upset for weeks. But my dad soon came to the rescue. He offered the idea of me acting as a volunteer coach for my younger sister's softball team. While skeptical at first, because who wouldn't be skeptical about coaching 10-year-olds, I soon came to love this new side of the game. After the long, painful journey, I learned the reason I encountered my obstacle, to share the love of the game with others through coaching. This experience taught me that there can be light, even when you feel like you are drowning in what seems to be darkness. So find the light in whatever you do. Always help others, because even though I don't experience the love for the game in the same way, I'm able to see it in the players I coach. Next year when I go to college, I plan to major in political science and eventually go to law school. In being a lawyer, I know it takes perseverance not only to get through school, but also to be in that profession. So I plan to take what I have learned from my obstacle and apply it throughout my life. And I will continue to help others in whatever I do. I am excited to see what my future holds, and I am excited to apply what I have learned. Thank you for listening.
Great job, Morgan. Thank you. Our second student for today is Charlie Mickelson from Lincoln High School. He is involved in Student Council, National Honor Society, Latin Club, golf, baseball, and he was the homecoming king. He is accompanied here by his parents, Mark and Cynthia, who are in the front row. Welcome. Thank you for coming. And plans to work in business or finance. So you got a lot of friends in this room, Charlie, who might want to recruit you in the future. Please help me welcome Charlie Mickelson.
Today I'd just like to talk about what my dream job was when I was a kid and how it changed as I matured. So when I was in elementary school, my dream career was to be an animal breeder because I wanted to make a cross between a falcon and an eagle, which I later learned was scientifically impossible. I also loved the idea of working with animals and truly believed that I was going to be an animal breeder. As I grew up, this mostly changed because I didn't view it as a very realistic job choice, as well as I lacked much interest in science, which is a big part of it. And I had a very big misconception about what an animal breeder actually does. It doesn't make new animals by crossbreeding or simply just breed animals. You have to study the genetics of the animals and decide which ones will produce the best offspring for meat production or milk, whatever it is. So as I matured, my interest in science dwindled, and I found new interest in statistics and mathematical classes. So I still don't exactly know what I want to do as I grow up, but I know it's something to do with either statistics or business or financial things. And I would just like to say thank you for having me here, and it's been fun meeting people here and attending the meetings the last couple weeks. And thank you.
Charlie, please see firstpremier.com/careers for more information. Yeah, well done, Morgan. Thank you for being here. Jen, Cynthia, and Mark, thank you for your parenting and for your service in our community and setting an example for our next generation. So thank you. Now on to our panel, and excited for our panelists that are up here. Our past president, Jason Herbold, will be moderating a conversation among three that you might be familiar with, but if you're not, I want to share a little bit about them before we go ahead and turn this over to Jason. First, from your right, Dr. Tim Ridgway is a Rotarian and is the 15th Dean of the University of South Dakota Sanford School of Medicine and a Vice President for Health Affairs. He's undergrad at doctorate or medical degree from the University of South Dakota School of Medicine. After doing a transitional residency at McKinnon Hospital in Sioux Falls, he completed his internal medicine residency and gastroenterology fellowship at Mayo Graduate School of Medicine in Rochester, Minnesota. He has been a recipient of numerous awards, too many to name here, but among them is USD Sanford School of Medicine Distinguished Alumnus Award. He has been a faculty member at the University of South Dakota School of Medicine since 1997. Welcome, Dr. Ridgway. Next, Dr. Crabtree, to your right, is the Vice President, Sanford Clinic for the Sioux Falls Region. He became the Vice President in December of 2019. In his current role, he has responsibility for physicians and advanced practice providers. He's a graduate of the University of Minnesota School of Medicine. He completed his residency in Duluth and obtained his MBA from the University of Tennessee. He's been with Sanford for almost 20 years and has held a number of different positions with that organization. And just to your right from Jason is Curt Hohman, Senior Vice President of Managed Facilities at Avera. Born and raised in Canton, and he went to the University of South Dakota, and after holding hospital management positions in both Denver and Phoenix, we're grateful that he returned to his home state of South Dakota and now lives not too far from where he grew up. Over the past 25 years, Curt has worked with the management and boards of 24 rural hospital campuses and has a direct responsibility for operations and as a consultant. These communities within the Avera network range in population from 800 to 12,000. And he estimates that he's participated in over 2,400 rural hospital board meetings. So a lot of experience, a lot of history, providing resources and guidance for our rural communities. So with that, I'll turn it over to past President Jason Herbold. Thank you.
Thank you, President Tony, and thank you all for joining us today. And to the junior Rotarians, Tony gave you his website address. I will give you my business card following this meeting. We'll just cut to the chase immediately. Dr. Ridgway, Dr. Crabtree, and Curt, thank you for joining us today. As when we were visiting last week, the common theme that came up is this is a broad subject. Rural health is a broad subject, and we have, 43 minutes to cover and solve all the problems as it relates to rural health. So I want to just thank you. We're going to try to do our best to cover the important high points and maybe get into a little bit of depth as the conversation unfolds. But as I mentioned, I'd like this to be more of a conversational discussion as opposed to a Q&A between me and all of you. So jump in wherever you feel fit. Tony provided an introduction to all of you, but something that I didn't know going into this is that all of you have a rural upbringing. You all grew up in small communities. I myself grew up in a small community, and that's not a surprise. We're in Sioux Falls, South Dakota, and we all have ties back to the small communities. But I would like to ask each of you, and perhaps we'll start with Dr. Crabtree and just kind of work our way towards me. Why is rural health something of importance to you?
Well, I think, thank you, Jason, for that. I think for me in particular, but maybe for many of us in this room, it's where our roots are. It's where my roots are. Ellendale, Minnesota is the hometown, 500 people. You grow up on a farm or other in those communities, and it gets in your blood. My dad always used to say, you can take the boy off the farm, but you can't take the farm out of the boy. Mm-hmm. And that was certainly true for me. Actually, before I got to college, I thought I was going to be a farmer. My dad had heart valve issues related to rheumatic fever when he was a little boy, which his cardiologist told him he needed to quit farming. That was a really sad day for me, leaving the farm as a 12-year-old. But it also gave me insight into why, and I didn't realize it at the time, but it gave me insight as to why having healthcare access, facilities, and so forth in small communities was so important. It was very important to my father and his ultimate care down the road. Briefly, we had, try to be brief, one of the stories that was a huge impact to me, my father had his third open heart surgery related to his valves, and he ended up with a condition called cardiac tamponade, which means the pericardium, or the sac around the heart, is a finite space, and he had bleeding into that space, and it compresses the heart to the point where it cannot beat. My sister came home from school, found him laying on the floor, they rushed him to the hospital. It's a snowstorm, rural Minnesota, can't transport him to the University of Minnesota where he had his surgery. This is a God thing, I'm convinced of it. The cardiologist who was doing outreach that day in New Ulm had to stay in the Holiday Inn in New Ulm because he couldn't drive back to Minneapolis. And between he and the general surgeon and the cardiac surgeon in Minneapolis, they did, before telemedicine was a thing, they did a phone call into the OR in New Ulm, performed a life-saving surgery for my father. And so, therein lies part of why, a significant part of why I'm passionate about rural health care.
Boy, that's a real story. Dr. Ridgway.
So I'm in charge of the state of South Dakota's School of Health Sciences and the School of Medicine. The mission of both of those schools is very clear. The state legislature has dictated to us, your mission is to provide quality health care for all South Dakotans. That includes urban and it includes rural areas. But it's also very personal for me too, because I grew up in a very, very small southeastern South Dakota community. I saw the incredible value of having healthcare providers there. I saw them take care of my entire family, from grandparents to parents to great-grandparents. And I also saw when that access was not available. And so it's not only the mission of the school, frankly, it's my mission. And I take that job very seriously, and that's why I'm really pleased to be here today to talk about it. Thank you.
Thank you, Dr. Ridgway. Curt.
Yeah, I think very similar to what these two have said, but I think the word that I would use is impact. I think, in a system or at an organization the size of Avera McKinnon, you can implement things, again, try to have an impact on people, on patients, and oftentimes you just don't see it. In a rural facility, you can start a new service, you can improve a patient experience, and you can see an impact right away. And so I think that's, it's nice to be able to tie an action that you did with you and your team and really be able to see that in a somewhat timely manner, an impact on patients.
Somewhat timely, right?
Yeah.
A discussion on rural health would not be complete without the accessibility discussion, and you brought that up, Dr. Crabtree. When I was preparing for this discussion, I went out looking for just good information, and there is not a shortage of information about accessibility and rural health, not a shortage. But I came across a piece written in 2019 by former U.S. Senator from North Dakota, Heidi Heitkamp. And I want to read you what she wrote in this article that she did for CNBC. It is as follows: families in rural zip codes have a harder time accessing quality health care, with services in remote communities much more limited than in denser metro areas. A wave of rural hospital closures is now compounding the problem, putting rural communities at serious risk of becoming health hazard zones. Can you take some time to comment on that quote and outline perhaps the reasons why not that statement is true? I'd like to start with you, Curt.
A couple things. First, just as far as I've seen this research before, I want to say, I can't remember which study it was from, but it showed that since 2013 to 2020, 100 rural hospitals have closed. And they looked at what was the impact on patients. And the average drive time for a patient to receive inpatient care went from about 4 miles to 29 miles. And so we all know in an emergency situation or, again, just a convenience factor, there are barriers, transportation issues, there are barriers to accessing healthcare. And so certainly that is something that I would point to as being, I guess, backing up her statement. I think the other thing I would say too is there is plenty of research, and maybe Dr. Ridgway can talk more about it too, but you know, heart disease, cancer, suicide, those incidences are much higher in rural communities compared to urban population. So I think it's 1.5 times more likely to die of suicide in a rural as a rural resident versus an urban resident. So again, a couple things I think that really back up her statement.
What are your thoughts, Dr. Ridgway?
You know, Curt, over the years, there's been a migration of population from rural areas into the more urban areas. And we have to keep in mind that it's one thing to have that primary care provider, the family physician in these rural communities. But if that primary care physician is going to deliver babies, for example, they need backup, cesarean section backup. You're not going to find obstetricians in these rural areas. So the general surgeons are there, and the general surgeons also help to support this hospital. Financially, it is a really narrow margin. Surgical services can play a role, a huge role. So as we see a migration of these surgeons away from the rural areas, we also are going to see obstetrical care, and everything else follows suit. And as you said, Curt, it is true. We're seeing less populations in these rural areas, and yet we're seeing a preponderant increase in mental health issues, diabetes, chronic heart disease, mortality. And yes, I think it is becoming a crisis, but I also am positive. And I think the very fact we're having this forum today, I think there's some good things on the horizon if we stay focused.
I would agree with that statement, all of the statements made thus far. One of the challenges I think that maybe you don't always see with this is when you see rural hospitals close, there's almost an $800 per capita decrease in income in these communities, in average income, and you'll also see unemployment go up by about 1.6 to 1.8%. The key is that the hospitals in those communities are one of the major employers, and so you're going to see a significant impact to that. And that when hospitals go away, to your point, Tim, when hospitals go away in these communities, the ability to attract any healthcare professional, whether you're talking physicians or you're talking nursing staff or respiratory therapists, occupational physical therapists, that ability to recruit those folks into those communities decreases significantly as well. So if the hospital in a small community goes away, it's a harbinger of maybe not so good things to come.
Obviously, healthcare scale is very, very important. It's very, very difficult to scale in a rural community. When you think about the funding mix that exists in the rural communities, is that also a barrier to the economics of a healthcare facility in a small community? How does that work?
In a rural healthcare facility, in rural areas in general, there are a preponderance of underinsured and non-insured individuals. There's more Medicaid, more Medicare recipients. That alone leads to funding issues. And then again, you get to all these other factors where you need the surgical care, you need the specialty care. That's what drives the dollars. When they're not there and you're left with primary care physicians that can't deliver babies, that don't have that backup, it's just a domino effect, and definitely limits the funding to support these institutions.
Mm-hmm.
One thing that I think that a lot of healthcare providers in the state have banded together and have really gotten behind the Medicaid expansion effort. We've got almost 44,000 South Dakotans without insurance that would be eligible if we did expand Medicaid. And again, to your point, Doctor, that is, would improve the economics. It would certainly improve the impact on patient care as well. If you don't have insurance, you probably don't have a primary care provider that you have a relationship so that he or she can tell you when you need to have checkups, when you need to have your preventive services, those types of things. So I think that could be a great solution. Millions of dollars to this state could result from the expansion of that program.
In 2020, Forbes magazine wrote that, so a year ago, 1 in 4 rural hospitals were at risk of closure, 1 in 4. And you commented earlier that, it went from 4 miles to 29 miles, I think is what you said. Are we facing similar math in this region of the country? And I'm thinking South Dakota and just this general area. What about you, Dr. Crabtree?
I think that certainly the risks are ubiquitous across the country in rural footprints. I think, Curt made mention that some of the health systems in the state have banded together to work on ways to help maintain our rural health networks. I think that's been a positive for this region in that the health systems have indeed taken on an initiative to do that, and that may impact, maybe we're not quite to that 1 in 4 risk, but at the same time, the risk is still there. So I don't think we can't take our eye off the ball as far as that goes.
What about on the reservations? There's a gap in the rest of rural South Dakota. I have to assume that the gap for accessibility is even more difficult. Maybe I'm just being presumptuous there. What is your assessment of the accessibility, and how do we contrast that with the rest of rural South Dakota? Dr. Ridgway.
Well, our reservations are if you think about it, they're in the most rural parts of South Dakota. You add to that the Indian Health Service and the extraordinarily lack of funding in those areas. So access is a huge problem. Then you add poverty. We know that if you take someone at an extremely low income level versus someone that's in the middle of the high income level, and you look at longevity, huge difference. The average life expectancy for a U.S. citizen, 79 years. You look at our Indian reservations, 58. So it is a profound problem. We're dealing with a compounding of, it's a very rural areas of the state, and we have extreme limited accessibility in those areas, and we have extraordinarily limited funding to develop those areas.
Just one shocking fact as well. The funding for our Native American population, our population that we have in prisons is more highly funded than for our American Indians. So it's that bad.
And then you take the scenario where in a rural community that's not on a reservation, and the access and the ability to recruit staff into that or people into that area is challenging. And you take that and multiply it by a significant factor, trying to recruit a physician or nurse or other staff to go to work for Indian Health Service to provide those services. So it widens that accessibility gap even further when you cannot bring professionals into those areas.
Are there any programs, incentives to encourage physicians, whether at the early stage of their career or later stages of their career, to go and practice on the reservations?
At the medical school, we have very strongly focused efforts in that. Number one, we have a huge pipeline program, and we're starting to see the results of that. 10% of South Dakota's population is Native American. And so we are going to the high schools. Our medical students are going out there, and they're talking to these kids, and they're saying, look, you can do this. They're bright. They just need to have the advantages that others do. This year, our admitting class, we had 5 Native Americans come into our class. Now, that puts us number 1 in the country, but as our former dean used to say, that's a low bar. We have to continue to do that. But the hope is, as we get these people in, they will go back. In addition, we are working and getting more and more clinical rotations for our students to go to these areas. This generation of student is very service-oriented. They want to give back. And so we're getting them into these communities, and they're seeing the value, the absolute love of what they're doing, and the people are responding to this dramatically. So from an education standpoint, we are really working to try to get our future healthcare providers to say, you know what, I want to go to these areas. I want to give back to these communities.
Avera is providing $24,000 a year in scholarships devoted at University of South Dakota Medical School, and they are devoted to Native Americans. And so, again, another incentive for that. We do $5,000 a year also for South Dakota State University for students are going to healthcare-related majors, again, from 9 tribes in South Dakota, but also in the surrounding area as well. So, again, trying to knock down those barriers, like you say, get that spark in them, and then certainly we want to help them financially as well.
We're spending some time talking about physicians, but there's nurses and nurses assistants. And in my experience, that's almost crisis-like too. How bad is the gap there in our rural communities and on our reservations?
It's become more of a gap lately. I think everybody is aware of staffing issues now at this time, post-pandemic, well, hopefully on the way out of pandemic. But it's significant in those areas that you mentioned. And to that end, not only are we and others providing scholarshiping opportunities for clinicians, physicians, but also in our nursing staff, respiratory therapy staff, surgical techs, circulating nurses in ORs, respiratory therapists. These are areas that are critical needs all over, not just in Sioux Falls. Yes, they're critical here, but they're critical in other areas too. So if we can scholarship in those areas, identify those people early, get into high school classrooms and be talking about, some of us as high schoolers probably didn't even realize that a respiratory therapist was a career option for us. So getting into the classrooms and talking to these kids, youngsters, about what opportunities and options there are out there, that's going to be critical as well. And I think one other comment, just to the last question related to how do you encourage those folks that are coming from reservations or coming from rural areas. I think some folks didn't even realize that they could be a physician or a nurse and come back. And then the second thing is many of our clinicians, or I'll say healthcare providers to encompass all of the job titles we've talked about already, many times they've got a significant other. And so why it's important for our communities to be robust and financially progressive in some of our rural communities is because we're not only recruiting the physician or the nurse or the respiratory therapist. A lot of times what's going to get that person to come to our community is if there's a job for my spouse or my significant other. And so if we can impact those areas, we're going to be more successful in bringing people back. It's a connection. This is my story. I'm a family physician. I worked in Laverne, Minnesota for almost 18 years. And the reason I went to Laverne, small town Laverne, is because my wife was from Laverne. That's how I got connected to that community. So recruit the professional, but also recruit the spouse.
One of the advantages I've had as Vice President of Health Affairs is I not only oversee the medical school, but I oversee our huge School of Health Sciences, nursing, physical therapy, occupational therapy, and don't forget social work.
Yeah.
What we have learned is that our country is technologically, and I would argue South Dakota, technologically way above the mean in terms of all the procedures and things we can offer to our patients. But what we're finding are the social determinants of health. We can see a patient and we can prescribe insulin, but if there's no follow-up to where that patient's going, and who's going to ensure that insulin's delivered? Who's going to ensure that blood sugar's followed? Who's educating that patient? It's all those kinds of things where you need a social worker and others to direct that team care. And that's where all these social determinants of health come in. Do they have broadband access? Are they health literate? Can they communicate with their physician? All of those things. And so what we're trying to do at the school is we're getting all of these professions to interact, to learn to communicate with each other, because that's going to prepare them, in my opinion, for the workforce of the future.
Great points. I don't think we can talk about nursing shortage without talking about the nursing shortage that we have and certified nursing assistants in our nursing homes in South Dakota. I don't know what's beyond crisis, but maybe we have a crisis, in hospitals. We are beyond crisis in long-term care. Of the 6 states, I think it is, that touch South Dakota, one state provides better reimbursement for Medicaid than South Dakota, and that's Iowa. And so all the rest, one has worse funding for Medicaid in long-term care than South Dakota. All the rest of them offer better reimbursement, which again improves the economics, which allows you to provide better wages to your nursing staff, and again, more success in recruiting. So it's a huge challenge for us in long-term care as well. That component is very difficult. To get back to your question from a couple questions ago too about how fragile are the hospitals in South Dakota. Again, I think there's a lot of good system support. Sanford does a great job of supporting their rural network. Avera does as well. Monument does as well. And there's independents that have strength as well. But I'll tell you, the ones that seem to be at higher risk, we'll put it that way, the ones that are connected to nursing homes. It is the economics don't work. They haven't worked for many years for the long-term care piece. And again, that's just that part of the campus that has to be subsidized by everything else. And again, the money doesn't balance out.
And if I can just add on to that, one of the reasons why the long-term care facilities have been able to make it is because they're connected to the hospital. So if the hospital goes away, the long-term care facility probably goes away too.
So the business model for an independent nursing home, assisted living home is worse even than a typical hospital system. So if you compound an already difficult situation with the fact that it's just tough to scale in a smaller community, you have a crisis-like environment, and it's even difficult in the urban areas when it comes to nursing homes. Dr. Ridgway, a little bit through your lens at USD, you're right in the center of any solution that's gonna come forth when it comes to rural health. You think about the economics, you think about the gap in trained professionals to treat the whole human experience, the whole human. What is USD doing right now, particularly the medical school, to help address some of the things that we've been talking about?
I could speak for an hour on this, but I'll really focus it. Number one, we know that you've got to get kids with rural experience, rural backgrounds, if you're going to hope to get them in there. This year, our admitting class, 53% came from communities less than 30,000. 35% came from communities less than 10,000. We have our Frontier in Rural Medicine program, which has been a phenomenal success, where we take kids in their first clinical year of training. We put them in small communities, and they become engaged in these communities. And it has been a wild success. We're producing graduates now that are coming back and giving back to these communities. But I think people think that if the School of Medicine would go away, well, we're just not going to get healthcare providers as much. We have something called the Center for Rural Health, and it's overseen by our chair of family medicine, Dr. Susan Anderson. $6 million in grants and counting to small areas. Recently, West River got a $2.5 million grant. They're training EMTs. There's a huge shortage of EMTs in these rural communities. Certified nurse assistants, they're training these. We're offering, once those people get there, they need support. The medical school is offering, we're telehealth, we're communicating, we're educating them, we're giving them support that they need. So all those things are making a difference in our rural communities. We're exposing them to family medicine and rural health in their second year of medical school, and then again in their fourth year of medical school. And then we're offering numerous electives, particularly on the reservations, so that they can get opportunities there. We have family medicine residency programs in Rapid City and Sioux Falls, and most recently, and I'm really excited about this, Pierce, South Dakota. Years ago, some of you may recall, the family medicine had a residency in Watertown and Brookings, and it was wildly successful. 100% of the graduates from there stayed in South Dakota. For funding reasons, those were disbanded. But we recently initiated another one in Pierce, South Dakota. And to date, those graduates are all going to rural areas. So we're looking at this from who are we bringing in, how are we training them, and in addition, we've got people in our Department of Family Medicine and our Center for Rural Health working on bringing in grants to provide the training opportunities for these communities and to provide support for those areas.
Thank you. I am a data guy, so I tend to be very driven by the math of things. Is there like a number or set of numbers out there that the three of you and your colleagues are watching to try to, sorry to put you on the spot, you're watching to try to fill the gap that exists with accessibility in the rural communities?
I don't know if there's any specific numbers that we're watching to say, you know, here's a percentage or, you know, time to next availability. But one of the things we watch within any one of our clinics is, you know, as to do we need another healthcare professional, is what's the time to the third next appointment, right?
Sure.
So if you call in and said, okay, I can't get one on this day, but the third next available appointment, if you're more than a few days out within a community, that's a real challenge. That means you have opportunity relative to getting people in. You've got people that might be leaving your community or leaving your clinic to go there. Fortunately, we don't have a lot of that issue in Sioux Falls right now. Our access seems to be pretty good. But you get out into our rural facilities and we certainly have those issues.
Okay.
This is kind of hard to, I think, visualize, but nationally, it's one physician for every 2,300 people. In rural communities, the average is one for every 3,500. And that is kind of the standard that's used. If you're below that, you are in a shortage area. And within South Dakota, 49 of our 66 counties are in a shortage area. And so again, they're below, they have more population than that 3,500 for every physician.
Well, we could spend a lot of time on just that topic, but we only have a few minutes to go, and I want to get to a couple other important topics. Mortality rates. So I think it was you, Curt, who commented on that earlier. I grew up in a small community. I talk to my folks all the time. And, you know, while it's been 25 years since I've lived there, and the people that I know from my small community make up probably about 1% of my total universe of people I know. I swear they make up about 90% of the unfortunate health circumstances. And that is an anecdotal throw out there, but it seems that way. Is that anecdotal example accurate on what really is going on out there? I mean, is it just that much tougher to live a healthy lifestyle in those rural communities than here in Sioux Falls?
To some degree, you're right. I mean, I'm sure some of it is you perceive that because you're in a small community, but to some degree, you're right. Any city in the United States, let's take New Orleans, for example. You can have a small community in New Orleans and have a life expectancy that's pretty reasonable. And then you go 2 to 3 miles away, and their life expectancy is 15 to 20 years less. And you can pretty much predict that, and it's been demonstrated actually in almost every urban area in the United States. You can correlate that with South Dakota when you look at Sioux Falls and Rapid City versus our rural areas. And again, it relates to what I referred to earlier, is these social determinants of health. Accessibility, transportation, education, water, all the things that play into the quality of health of an individual. And so that's why we're all here today, right? I mean, it's not only about getting healthcare providers there, but getting that infrastructure there so that these people have equal opportunity that those in more urban areas do.
Quick story for you. We've got an accountable care organization, the short answer to that is, what is that? It is incentivizes healthcare providers to really care for the whole person and try to promote health and, again, prevent them from needing hospitalization, emergency rooms, those kind of things. We had a patient who had COPD and asthma, and so again, very difficulty breathing. We ended up, again, making a site visit to her home, and the best thing we could do for her health was buy her a window air conditioner. The humidity, the heat of the summer caused her, exacerbated her COPD. And that's kind of the social determinants of health that we're talking about here.
Exactly.
Is that, like, how in the world would you think an air conditioner and, could improve her life that much? But that's just kind of a little backing up exactly what you're saying.
And with accountable care organizations, you can do that. But with our payment system now, not allowed. It's RVUs. It's what have you done? What's the service you provided? And that's it. But if you can incentivize those clinicians to ask about living conditions, those types of things,
Right.
And that's a great example, Curt.
If you were to ask anyone off the street, where's the safest place to live, with a lot of things that are going on in the media right now, you might not say that Minneapolis is safer to live than, Menno, South Dakota. The fact of the matter is Menno, South Dakota is not safer than, statistically speaking, and I'm not talking about gun violence or violent crimes, but you're talking about the ability to have an ambulance ride because I'm having a heart attack, to be able to access care, access to preventive services so that I don't end up in the ER. These are the things that contribute to that ability. 22% is the number that I read this weekend. 22% less safe to live in rural America than it is in urban America. So to answer your question, is it accurate? I think it probably is on some level.
Yeah. Every time I say that to my folks, they get irritated with me.
Yeah, they do.
Please, I hope this is not covered in the media.
Don't say, how are you feeling, Mom? Never ask that. I mean, it's 45 minutes later, you'll get the story.
That's right. The air conditioning. I mean, some of the moments in my life where I've been the most distraught was when I didn't have air conditioning. Let's talk about mental health. I imagine when all of us were growing up, mental health was not even in our vernacular. It is now in everybody's vernacular. And it's clear that, from what I've read at least, that mental health is even worse of a challenge in rural communities than it is in urban communities. And I think, Curt, you said that it is 1.5 times the suicide rate.
Correct.
Right? Did I get that right? What are the underlying reasons in your views why that is, and what are we doing as a state through the medical school and through the hospital systems to address it? We'll start with you, Dr. Crabtree.
So, agree that mental health was not part of the vernacular 20 years ago. It needs to be more of the vernacular. We are seeing an increased need for that. It seems like every time you turn around, you're reading legitimate studies that are saying, yes, the demand, the need is going up and up and up, and the number of resources or the ability to service that need is staying the same, or maybe even going down in some communities. Relative to our rural populations, one of the reasons why it's more challenging, I think the willingness to accept and talk about it and put it out there into the lay press or the lay culture, the lay language is not nearly as great. It maybe hasn't progressed to the point where it has in our urban counterparts. And it needs to change, and we want that to change. There's light at the end of the tunnel, I think. You know, one of the things that has happened through this pandemic is telemedicine or access. Mental health is one of those areas of wellness that lends itself to a telemedicine option. You know, there's not much in the way of physical studies that have to be done. There's not a lot in the way of examination that has to be done relative to the physical body. So the ability to sit in your living room and talk to a physician or a clinician or a social worker is much easier and probably much more comfortable. That stigma which prevents us from having or being able to have those conversations on a regular basis. You don't have to get in a car. Nobody has to see you walk into your psychiatrist's office or your psychologist's office. You don't have to sit and look across patients across the room for that. So I think there's definitely more opportunity there for us, and I think we can do a better job relative to that. But certainly there's issues there.
Yeah, small communities. You're in a fishbowl. Mm-hmm. And even in urban areas, nobody wants to talk about mental health. And I think it's even magnified in these rural areas. I think you're right. Our psychiatry residency program at USD, we've got students in there now that are very much interested in rural mental health. Now, again, they'll have a spouse, right? And are they going to go to a rural area? Perhaps not. That's where telehealth comes in. I think that's very, very important. And we're training these students now. There's a way to deliver telemedicine and ways not to. And so that's a whole new vernacular you have to teach them. But I think it's got real promise in the future. In the last 3 years, I've written letters for students, and they all are from small areas in South Dakota. They said, I want to come back and I want to give to these rural areas. And many of them are in our residency program, some are not, but they all say they're going to come back. I think there's hope there.
The area that's growing the most that I'm told by our people at behavioral health at Avera is under 12 is the diagnoses for behavioral health related illnesses are just exploding. You might see the big expansion we're doing in Behavioral Health Center. One of those units is for kids 14 and under, is that unit will be dedicated to them. So it is a huge problem. And again, the access in rural communities, particularly again, devoted towards children, is extremely slim or none, not available.
We got 2.5 more minutes, and I want to ask each of you, we've talked a lot about the challenges. We spent some time talking about things that each of you or through your organizations are doing. But obviously this is a problem of epic proportion and complexity. I'd like each of you, if you're willing, to just comment on one or two things that you feel we should be prioritizing, whether that's from a policy standpoint or from a profession standpoint, to nip some of this in the bud right away. I'll let whoever wants to take it.
I'll take that first because I feel pretty strongly about it. Policy standpoint, our reimbursement system to healthcare providers, in my opinion, needs to change. I, as a gastroenterologist, can get paid a fair sum of money for doing a 30-minute colonoscopy, whereas that mental health provider that may spend 90 minutes, which is really wrenching with a patient, they will get paid a fourth, if that. That's wrong. The incentives are to do procedures, to do these high-tech things. Now, don't get me wrong. They're life-saving. They can be a benefit, but it's at the expense of these other things, these preventive measures we've talked about, all the things that we need to do in the rural areas. Our kids graduate from medical school. The average debt when you graduate from the University of South Dakota from medical school alone is $180,000. The reimbursement, if you go into a specialty, no problem. Primary care, go into a rural area, you're going to paying debt for many, many years. So I really feel we need to change policy. We need to change our reimbursement system to make asking about that patient, where they're from, their living condition, what's going on, make that as much of a priority as doing a procedure. And I think that can make a real impact in what we're trying to do for rural health.
Thank you, Dr. Ridgway. Dr. Crabtree?
I want to echo that because I'd like to, if there's anybody listening, I want to go on record that I would support that too. But I think also, I said this a little bit earlier, but I'll just reemphasize. I think one of the ways that we have to really focus on improving or building is with just the overall rural economy. If our rural communities are doing well, they will then be able to draw folks in. I think, and that's a non-healthcare related answer maybe, but I think it's really important because it's obvious that if the healthcare systems or the communities aren't doing well, the healthcare systems in those communities aren't going to do well, we're going to lose our professional staff that will come back. And then the other piece, and then we won't have a health system there. And then the other piece is encouraging, identifying those folks that may have an interest in a healthcare related career and connect with them early. Connect with them when they're juniors in high school, seniors in high school, and foster that relationship and develop that, because that's how we'll get them back into our rural communities.
So our two young Rotarians in there, hopefully we've got you interested in healthcare now. Come see me afterward, okay?
I've never had an original thought, so I'm not going to start now. Great point with, I'll take the policy side, but again, also just what can we do? I agree. Workforce is the biggest challenge, I think, for our rural communities as it relates to hospitals, clinics, nursing homes. And so it is really having that attractiveness to get the workforce there and to keep the workforce that we have. I think to piggyback on, again, what Dr. Ridgway was saying, right now it's kind of interesting, and particularly talk about behavioral health, but it's with everything. With telemedicine, with the advent of COVID, we haven't even said that word yet. I can't believe it, but I think we use it all the time, don't we? With COVID, they allowed us to see patients in their home. Before they had to, in order for us to get payment, they had to be seen in a clinic or a hospital or setting like that, medical setting. They also pay us the same as if it were a face-to-face visit. That parity in reimbursement has got to stay. Yes. We have plenty of expenses. You don't have to take my word for it. We can share it after we're done about the expenses that are associated with a telemedicine visit versus face-to-face. It's very, very similar. So we need that. Also, kind of the telehealth 1.0 was, and Avera started in 1993 with telemedicine up to Flanders, South Dakota for a psychiatrist there. We need to get to 2.0, and that is where what I think both of you have been talking about is we can visit patients in their home on a much more routine basis, as opposed to, okay, we'll come back in 3 weeks, or I'll talk with you in 3 weeks with how you're doing, how your medication is doing, that kind of thing. So we really need to get to that level of getting to the patient right in their home, which a lot of other factors we could talk about there too.
Well, gentlemen, I want to thank you for joining us today. We are unfortunately out of time, and as I started off, we knew that this was a big subject, and we could barely scrape the surface. But I want to emphasize, I could tell by just talking to the three of you that you have a passion for this and a passion for the rural communities. And everybody in this audience and everybody that's tuning in is only one generation away, if not the generation on the rural community, one generation away from the rural communities. And they're an important part of our economy, and they need some help. We need some help here. So I want to thank you for joining us. If we can give these three gentlemen a round of applause.
Thank you, Jason. Thank you, Curt, Dr. Ridgway, and Dr. Crabtree. It's great to have 4 individuals from rural communities talking about solving issues in rural health. And with the 3 of you individuals working hard and diligently, I know there's hope and optimism for a better tomorrow in our rural communities. So I want to thank you for that. And it's great to have 2 competing health systems working together towards solutions that can better our state and better our region. So appreciate that. Looking ahead to next Monday, excited for a panel If you've been watching the news, everyone has been talking about getting out and shopping early, especially if that gift that you want is going to end up underneath the tree. We're going to have a conversation about retail. We're going to have Jody Schwan here. We're going to have Rotarian Joe Batchelor of downtown Sioux Falls, as well as Dan Geese from the Sioux Empire Mall, talking about retail, what to expect, and what to look forward to as we head into the season. The other thing you can look for in November, we're going to have a membership drive where the one-time $100 fee to join Rotary is going to be waived. And we're going to go with the Rotary International theme of each one bring one. So please look to bring guests. We're going to make a big push in November here prior to the holidays, and appreciate you bringing those other leaders in your life along to have them experience some of the conversations that we're having here at Downtown Rotary. With that, Rotary is adjourned. Have a great week.